আজকে দুটো টপিক নিয়ে আমাদের ক্লাস রয়েছে। First, so you can see that is epidural and caudal anesthesia, and another class is on regional anesthesia. Acha, first tell me what are the type of anesthesia you guys know about. কি টাইপের anesthesia হয় তোমরা জানো সেটা আমাকে বলো। Sorry? Local anesthesia and general anesthesia. আর spinal anesthesia, right? তো বেসিক্যালি জেনারেল অ্যানেস্থেসিয়া আর নিউরাক্সিয়াল ব্লক, ঠিক আছে? তো নিউরাক্সিয়াল ব্লকের মধ্যে স্পাইনাল অ্যানেস্থেসিয়া আসে। আদার দেন স্পাইনাল অ্যানেস্থেসিয়া we have another type of anesthesia, that is epidural anesthesia. Epidural and caudal both are the same type of anesthesia, just কোন এরিয়াতে হচ্ছে তার উপর বেস করে নেমটা চেঞ্জ হয়। So according to the the definition is epidural anesthesia is a neuraxial technique for that gives broader application than a single dose spinal anesthesia, because spinal anesthesia you give one single shot of the drug, that's it, you can't do anything. In epidural anesthesia you put a catheter over there through which you can give drugs and you can prolong the duration of the surgery. So application কোথায় কোথায় পাওয়া যাবে? In different surgeries, abdominal surgeries, obstetric surgeries, like that. Okay. So before getting into detail, we need to know about a little bit of anatomy of the spinal cord. So what is the covering of the spinal cord named? কি বলে? Spinal cord এর cover কে কি বলে? What? Meninges. And what are the layers of the meninges? Right. মানে একদম ভেতরে থাকছে pia mater, then comes arachnoid matter, and lastly there is dura mater. And above dura mater there is another layer, that is not the layer of meninges but another ligamentum layer, that is called ligamentum flavum. Okay. So epidural space lies in between the dura mater and the ligamentum flavum. See, this blue portion is the dura mater, this is the arachnoid matter, and this yellow portion is the pia mater that is attached to the spinal cord. Now above the layer, that dura mater, there will be one ligament, okay, that is called ligamentum flavum, and the space in between is called the epidural space. So we use that epidural space for giving anesthesia. So what are the indication, for what reason we use epidural anesthesia? See, it's written over there like intra and post-operative analgesia, like during the OT and after the OT, if you need to give analgesia or you need to keep the patient pain-free, so that is being given by epidural analgesia. It is being used in thoracic and abdominal surgeries, okay, and with spinal anesthesia for prolongation of the surgery. As I said, like if you are giving spinal anesthesia, it's a one-time thing. You are giving one shot of drug, that's it, you can't do anything else. And one spinal anesthesia will last for maybe like 2.5 hours, like that. After that, if the surgery prolongs, so what will you do? You give epidural analgesia along with the spinal. For the first 2.5 hours period, spinal anesthesia will work, and after that if you need to prolong the surgery, you need to activate the epidural analgesia. And you must have heard about the labor analgesia or walking epidural, like patient will be having painless labor. Labor will be there but there will be no pain. That is being done by epidural analgesia, okay. And also it is used in chronic pain management, okay. So what are the advantage? In spinal anesthesia, we basically give injection to the subarachnoid space in the CSF, okay, and that causes sympatholysis, okay, that cuts down your sympathetic system. Therefore, there will be chance of hypotension. But in epidural analgesia or epidural anesthesia, you don't give any drug to the CSF directly. Rather, you keep the catheter in the epidural space. Through there, you will be giving drugs, and that drug will act. So the chance of hypotension is much lesser than spinal anesthesia. And there is no post-spinal headache. Like one thing is happened when we do spinal anesthesia, we basically puncture the dura mater, okay, and then we get inside the subarachnoid space. So there is a dent inside the on the dura mater. So even after withdrawal of the lumbar puncture needle, the CSF will leaking from that injury or that space. So and that causes headache. That is called post-dura puncture headache. But in epidural anesthesia, we don't get to see this because there is no leakage of the CSF. Acha. And level of block can be changed. That is advantage. Like since we put a catheter inside the epidural space, we can manipulate the length of the catheter inside the epidural space. If we need to make it higher, we can introduce some more amount of the catheter inside the epidural space and we can give drugs. That is how we can change the level of the anesthesia. Okay. And of course, as I said, duration of the surgeries can be prolonged. Acha. So for epidural anesthesia, we need to see what are the instruments we use. Basically, you can see a picture over here. This comes in a sealed pack, all sterile, okay? And it has 4 or 5 components. Like you can see a syringe, needle over here. That is 18 gauge Tuhi needle. It is called Tuhi needles, okay? Then there is a catheter. I was talking about a catheter continuously from the beginning. So this is a catheter. You need to introduce this catheter through this needle, okay? This is the tip of the catheter that will be inside the epidural space, and that is the other part of the catheter that gets connected to this connector, okay? That is called lock connector. And you can see a white space over here. From there, you push the drug inside the epidural space, okay? And one thing very important, that is this 10 ml syringe, that is called LOR syringe, means loss of resistance syringe. You are inside the epidural space. You need to confirm that you are inside the epidural space and in no other space, or not in the soft tissue. How will you understand? By this LOR syringe, okay? Now we'll know a little bit about the technique. So first we need to prepare the patient, okay? Patient preparation is very important because whenever you will be doing any procedure, maybe it's spinal or epidural or GA or any surgical procedure, you need to explain the patient what you are going to do. You need to take consent of the patient. If after explaining everything, patient is not giving you consent for doing the procedure, you are not going to perform that, okay? So that's why you need to explain the patient everything. You take consent, and then comes the monitoring resuscitation equipment. What is that? You all have come inside the OT. You have seen the OT is happening and the monitor is over there. Vitals are being checked. What are the things? Like BP, pulse, SpO2, heart rate, everything is being checked, because if you are giving epidural or spinal, there will be chance of hypotension. Little bit of hypotension will be there even with epidural. So you need to check the vitals. Even if you are giving drugs from there, there is chance of drugs being getting inside the intravenous route. So that can cause some hypertension or tachycardia. So you need to check everything. So that's why you need to monitor the patient. And also you need to keep the resuscitation trolley ready. You guys have done class of Dr. Atif Siraz, right? The previous anesthesia class, there was a about resuscitation trolley or something like that. Acha. Before, like inside the OT, we have one resuscitation cart ready always. Like during the OT, if anything happens, you need to resuscitate the patient. It's not like patient is having any problem, you won't be doing anything. You have to, like if patient is having a cardiac arrest, then you have to give CPR and revert back the patient. That's why you need certain drugs. Sometimes your patient is having surgery under spinal anesthesia, and you need to give the patient general anesthesia. You need to convert the OT into general anesthesia. Then you need to have those laryngoscopes ready and ET tube ready. Otherwise, you won't be able to revive the patient. Okay. So that resuscitation equipment should be ready. And also the intravenous access. As I said, there is chance of hypotension. You need to have good intravenous access to the patient, and you need to give fluid to the patient. Okay, so that's how you'll prepare the patient first. Then you need to position the patient, like you'll choose whether you'll do the procedure by making the patient sitting or in lateral decubitus position. After that, we'll do the strict asepsis and sterile drape. Like you have seen, when we give anesthesia, I mean spinal anesthesia, we clean that area with betadine and spirit. Okay, so you need to first, because you will be pricking the skin, and skin is, I mean, there are a lot of bacterial contamination over the skin. So if you don't clean the area and you introduce, all those bacterial things will get inside the CSF, and that might cause meningitis. Okay, so we don't need that. That's why we'll be doing strict asepsis and sterile drape. Okay, and after that, site of needle insertion according to the site of surgery. Now, what does that mean? You can see the vertebral column over here. These are the cervical vertebra. This portion is the thoracic, this is lumbar, and this is sacral. Okay. Now, what kind of surgery is happening? According to that, you need to change your epidural anesthesia. If any surgery is happening over the cervical, vertebral space, you can give epidural through this portion. Okay. For any thoracic surgery or upper abdomen surgery, you will be giving epidural anesthesia through the these vertebral spaces. Thoracic vertebral spaces. And for any lumbar surgery or like lower limb surgeries or lower abdomen surgeries, you will be performing epidural anesthesia to the lumbar region. Okay. Now, there is sacral region also over there. So, if you need to give epidural anesthesia through the sacral region, that is called caudal anesthesia. Okay. We'll be discussing about that later. Okay. Now, what are the technique of epidural anesthesia? First, we need to pass the epidural needle through the skin. Like after all the preparations, we need to, that I showed you that syringe, this needle, okay, this one. You need to pass that epidural needle through the skin, and you need to get inside the epidural space. And how will you understand you have gone inside the epidural space? As I said, lower, but before that, there is, as I said, there is above the dura, there is one ligament that is called ligamentum flavum. Okay, and this is a tough structure because it's a ligament. So when you will be cutting the ligamentum flavum, you will there will be loss of resistance, exactly, and it will be like you will get a giving away sensation. Okay, so passage of the epidural needle through the skin and the ligamentum flavum must stop before piercing the dura. So after the sense of loss of resistance, you'll have to stop immediately. Otherwise, you can prick the dura accidentally, and then it won't be it won't be epidural. It will be a subarachnoid block. Like you'll be getting inside the subarachnoid space, and it will be a spinal anesthesia. So how will you confirm? Confirmation by the loss of resistance or hanging drop technique. For loss of resistance, you need to have that syringe I showed you earlier. Like what we do, we take air inside that syringe. We put it on the hub of the needle, okay, and then we press. If it is, since it is, that epidural space is a negative, space, it has some negative pressure. When you are inside the epidural space, the air will be sucked in inside the syringe. That air will be sucked inside the epidural space. Or there is another thing, that is hanging drop technique. Like you make a bubble in front of a normal syringe, okay, and you put it in outside the hub of the needle. Okay, since it's a negative, since there is negative pressure inside the epidural space, that bubble will sucked inside the space. Once it is confirmed that you are inside the epidural space, you will have to put the catheter inside. Okay, now placement of the catheter up to the desired level. After that, some portion of the catheter will still be outside the epidural space, so you need to secure it over the skin, and then you have to come the other part of the catheter, you need to connect it with the connector, okay, and from there you will be injecting the local anesthesia. Acha, there is that is one thing, it is called test dose. Test dose of local anesthesia. What is that? Immediately after, putting the catheter inside the epidural space, you don't give the whole amount of the drug. It's not done. You need to give a test dose so that you can understand it is actually in the place. It's a fail-safe method. It can happen like if there is accidental intravenous insertion of the catheter. In that case, if you give the drug, it will go inside the vein and it can cause seizure activity in the patient. So we don't do that. We don't want that. That's why we need to give test dose. In test dose, what we use, lignocaine and adrenaline mixture. So that adrenaline inside in the mixture, that will cause tachycardia and hypertension if it's going inside the intravenous route. So that's how we'll get to understand it's not inside the intravenous route. So what are the factors affecting level? Means what are the factors that affects the level of the anesthesia? Okay. So what are the factors? Volume of the drug. Like if you give more volume of the drug, the level will be higher. If you give less amount of drug, the level of anesthesia will be lower. Okay. Age of the patient. Since we all know, like with age, everything gets shrunken up. Okay. So the epidural space will also get shrunken up in aged patients. So if you are giving drug, like you are giving 10 ml of drug, okay, in a normal patient where the epidural space is normal, that drug will go up to a certain height. In aged patient, the epidural space is shrunken up, so that 10 ml of drug will go much higher, up to much higher level, and the level of anesthesia will be high. So we don't want that. So we need to, according to that, we need to change the dose or volume of the drug. Okay. Then intra-abdominal tumor and pregnancy. Both of them causes increased intra-abdominal pressure. In any intra-abdominal tumor or pregnancy, they increases the intra-abdominal pressure, and that also causes the rising up of the drug or rising up of the level of anesthesia. Site of injection, as I showed like in cervical or thoracic or lumbar or even in caudal area, sacral area, you can. Now speed of injection, thus if there is a certain speed, you can inject like 0.2 ml per second. That is the speed of injecting drug. Then patient position, if patient is sitting in sitting posture, so drug level will be lower. If you make the patient supine immediately after the drug, so it will go up. Anatomical variation of the vertebral column, like patient, sometimes you have seen patients of kyphosis, scoliosis or ankylosing spondylitis. In these patients, there will be anatomical, anatomy of the vertebral column is different. So you are giving a certain amount of drug and you don't know, it might goes up to higher level or it might not even rise. Okay. And also concentration of the local anesthetics. That also depends. That also affect the level of the anesthesia. So what are the drugs we use? We use local anesthetics. Along with that, we also use adjuvants. So what are the local anesthetics? Like lignocaine, bupivacaine, levobupivacaine, ropivacaine, those are the local anesthetics we use. And adjuvants are the drugs which used along with the local anesthetics to increase the duration or to prolong the duration of the action of the drugs. Now, how much drug you will be giving? There is also a dictum, like for each segment, for blocking each segment, you need to give 1 to 2 ml of drug. So here ends the epidural anesthesia. Now we will be going into the caudal anesthesia. Caudal anesthesia is the same thing. It's also an epidural anesthesia, only you are giving it to the sacral region. So that is the anatomy of the sacral hiatus. In other vertebrae, though every vertebra is separate, but in sacrum all the vertebrae are fused, except which vertebrae are not fused in sacrum? 5 and 6. Okay. So there is a V-shaped aperture formed due to lack of dorsal fusion of the 5th and 6th sacral vertebral arches. So here is the gap. You can't see properly. It's a triangular pattern or triangular shape over here. These portion and this portion, these elevated portions are called sacral cornua. Okay, and between that there is a gap or hiatus, that is called sacral hiatus. You go inside the epidural space through that sacral hiatus, and this sacral hiatus is covered by a ligament that is called sacrococcygeal ligament. So you need to pierce that ligament to go inside the epidural or caudal space. Acha. And now you think you need to keep one thing in mind, like we don't give caudal anesthesia to adults. Okay, this is mostly for pediatric patients and up to 6 to 7 years of age, not more than that. In above patient, like adult patients or elder childs, this caudal anesthesia won't work properly, okay, or effectively. So you'll be doing that for pediatric patients. So what are the indications? Same for like epidural anesthesia, like that will be prolong the duration of the surgery, and as an adjuvant to GA, like patient is having surgery under GA, then you need to give added analgesia to the patient, so you will be giving the caudal analgesia, and that will add up to the analgesia. Now there is another thing, that is chronic back pain unresponsive to conservative management. This is the thing where you give caudal anesthesia to the adult patients. There is one block called caudal epidural block that is being done in case of adult patients. Okay. And what are the contraindications? Like major malformations of the sacrum. Since we do that procedure in the pediatric patients, so some pediatric patient may come with spina bifida, okay, or meningomyelocele. So in those cases, you can't prick the area, okay. And also if patient is having meningitis, okay, if there is any infection inside the meninges, okay, you can't give or you can't prick that area. So these are the contraindications. Plus intracranial hypertension. If patient is having raised ICP, okay, like that happened in any RTA patients, road traffic accident patient, or there is head injury, or any intracranial tumor is there. So there will be raised pressure inside the cranium. And if you do any neuraxial block technique, or like maybe spinal anesthesia or caudal anesthesia or epidural anesthesia, so there will be herniation of the brain matter. Okay, so you don't do that. So if there is raised ICP, we don't do spinal anesthesia or epidural anesthesia. Now, what are the technique? First, we need to prepare the patient. How will you prepare a pediatric patient? In adult patient, you will be telling him the procedure and you'll be taking his consent. But in pediatric patient won't be giving you consent. So you need to talk to the parents. You need to get consent from the parents. After that, you need to make the child sedated, because there is a separation anxiety. When you will take the child from the parents inside the OT, he or she will start shouting and crying everything. So you need to make the baby calm. So first you need to sedate the baby, and then you will bring the baby inside the OT. Okay. And after that you will position the child. How will you position? There are two positions over here, like lateral decubitus and prone. We don't make the patient prone. We prefer to do it in lateral decubitus position. Then palpate the sacral cornua along the line of spinous process at the level of sacrococcygeal ligament. Then you will trace down the spinal process. I mean the spine over here, and you'll feel the hiatus. The sacral hiatus I was talking about. You can feel it from outside. From that sacral hiatus, anyway, so from there you will be going inside the caudal space. Now introduce the needle at the right angle to the skin. So when you feel the sacral hiatus, you put a needle over there at 90-degree angle, you pierce the skin, then make the needle a little bit kephalad, like towards the brain, and then you go inside. While you will be going inside, you will pierce the ligamentum and that sacrococcygeal ligament. Then again you will feel the loss of resistance, and that, see over here, like resistance felt on piercing the sacrococcygeal membrane, and then inside inject the local anesthetic with frequent aspiration. Why will we do frequent aspiration? Because we need to make sure that we are not inside any intravenous route or not inside the subarachnoid space. Because if CSF is coming, you don't give drugs, then it will be a spinal anesthesia. If inside the vein, you don't give drugs because it will cause seizure activity. Okay. Acha, what I said, that was the landmark technique. Like you feel everything and you are putting a needle inside the caudal space. There is also USG guided technique, that is, more advanced technique, and that is more but that is a correct technique. We should practice USG guided block only. So I'm not going into detail, but what you need to see, can you appreciate a frog face over here? Those are the eyes of the frog, and this is a face or mouth of the frog, like that. So you will get to see a frog face appearance in the USG, okay, and then you go inside the epidural or caudal space. There are the facts I already told about the caudal anesthesia. So what drugs do you use in caudal anesthesia? I have already shown you before, like bupivacaine, levobupivacaine, ropivacaine, lignocaine. You can give all of them, but there is a scale for calculating the drug dosage. That is called a scale of Armitage or Armitage scale. Since you are giving it into the pediatric patient, of course dose will be lesser. So, and that is be done by body weight, by measuring the body weight. So for all sacral dermatomal blockage, you need 0.5 ml per kg. That means if you are using that amount, 0.5 ml per kg drug, it will block below the umbilicus. Okay. If you are using 1 ml per kg drug, it will block up to the umbilicus of the child. And if you are using 1.2 ml, 1.25 ml per kg, it will go up to the mid-thoracic level. Okay, that's how you calculate the drug dosage. So that's it about the caudal anesthesia. But we have another region supplied by the nerve. তাহলে একটা nerve block করে দিচ্ছি আমরা anesthesia দিয়ে বা local anesthetics দিয়ে, and the area supplied by the nerve will get anesthetized. That is why the name is regional anesthesia. I mean, I can tell you at least 30 or 40 nerve blocks, but not possible in that class. And ওরকম ভাবে হয় না, you need to study a whole year for that. তো যেগুলো খুব important বা most commonly we use during the surgeries, I'm talking about all of them, like brachial plexus block, femoral nerve block, sciatic nerve block, Ilioinguinal, Iliohypogastric nerve block, and tab block. Tab block হচ্ছে transverse abdominis plane block. ঠিক আছে? তো brachial plexus block, first we'll talk about it. আচ্ছা, brachial plexus block এ যেটা important সেটা হচ্ছে anatomy of the brachial plexus. ঠিক আছে? এই anatomy of the brachial plexus শুধুমাত্র anesthesiaর জন্য important না. It's important for your anatomy class, for surgery, for orthopedic. Everyone needs to know about the brachial plexus. So এইটা কিন্তু সবাইকে memorize করতে হবে. Anybody can help me with the anatomy of the brachial plexus? কেউ বলবে? আচ্ছা, এটা মেমরি এভাবে করবে যে, see, it has 4 divisions like root, trunks, divisions, and cords, and after that there are the branches. So root se আসছে, root value কত? C5 to T1. Acha. Okay. Then C5 are, after the roots there will be trunks. তিনটে trunk. Acha. All the ventral rami are in use in brachial plexus. C5, C6 এর ventral rami নিয়ে হচ্ছে upper trunk. C7 এর ventral rami হচ্ছে middle trunk. আর C8, T1 এর হচ্ছে lower trunk. Okay. After the trunk, each trunk divides into two divisions, anterior and posterior divisions, and then it forms the cords. কি বলো? দেখেন না কিভাবে lateral হচ্ছে? Anterior division of an upper and middle makes the lateral cord. তাই তো? আচ্ছা, medial cord. আচ্ছা, and all the posterior divisions make the posterior cord. আচ্ছা, তারপরে হচ্ছে branches. There are certain branches from the roots, okay, like dorsal scapular nerve, long thoracic nerve. There are certain branches from the upper trunk, like nerve to subclavius, suprascapular nerve. And what is important, that is the branches from the cords, okay. And for that you need to remember the mnemonic. For lateral cords, whatever will be emerges will be lateral divisions, like lateral pectoral nerve, lateral root of the median nerve, okay. And one exception is that is musculocutaneous nerve. From the medial cord there will be medial branches, like medial pectoral nerve, okay. Then medial root of the median nerve, medial cutaneous nerve of the arm, medial cutaneous nerve of the forearm, and one exception, ulnar nerve. And from the posterior cord there is a mnemonic, that is ulnar, okay. You remember that ulnar, upper subscapular, lower subscapular, nerve to latissimus dorsi or the thoracodorsal nerve, then axillary nerve and the radial. So that's how you remember the whole brachial plexus, and I'll request everyone to practice it. এইভাবে ছবি এঁকে প্র্যাকটিস করবে, then you can keep them in memory, okay. আচ্ছা, now we'll be blocking those that brachial plexus, and that will cause brachial plexus block. কি অ্যাপ্রোচে করতে পারি? Interscalene approach, supraclavicular approach, infraclavicular approach, and axillary approach. The interscalene approach, the landmark is we have cricoid cartilage over here. Cricoid cartilage জানো তো কোথায় আছে? Below the which cartilage? এর উপরে cartilage কি থাকে? বলো বলো বলো। cricoid এর উপরে cartilage টা কি? 18 এর ওখানে থাকবে। মোস্ট প্রমিনেন্ট তোমার তো আছে, প্রমিনেন্ট ওটা কি? থাইরয়েড কার্টিলেজ, থাইরয়েড, অ্যাডামস অ্যাপল, থাইরয়েড। আচ্ছা, তো ক্রিকয়েড লেভেলে যে ইনজেকশন আমরা দিই, দ্যাট ইজ কল্ড ইন্টারস্কেলিনি অ্যাপ্রোচ। দেন উই হ্যাভ সুপ্রাক্লাভিকুলার অ্যাপ্রোচ অন দ্যাট এরিয়া above the clavicle. One is infraclavicular approach and another one is axillary approach, okay. So by interscalene approach, we use interscalene approach for the surgeries for upper arm, like shoulder surgeries or clavicle fracture, like that, or upper arm surgeries. এইগুলোর জন্য আমরা interscalene approach use করি। আচ্ছা, supraclavicular approach for the surgeries of the distal arm or elbow, forearm, hands. For these we use supraclavicular approach or infraclavicular approach. An axillary block is given for the forearm surgeries and hand surgeries and elbow surgeries sometimes, okay. এইগুলো হচ্ছে আমি যত নিচের দিকে যাব আমার level of anesthesia নিচের দিকে হবে, ঠিক আছে। And there are certain complications. এই যে complications কি? Since আমরা interscalene approach cricoid level এ দিচ্ছি, okay, তো এখানে কি থাকে? ইম্পর্টেন্ট স্ট্রাকচার carotid. তাহলে আমার there is a chance of carotid, injection inside the carotid artery. So that's a complication. carotid এ যদি খোঁচাখুচি হয় তাহলে ওখানে হেমাটোমা হবে, okay. So that is also a complication. there is if you মানে this area is nearby the your spinal cord, so there is chance of accidental spinal injection also. Okay, আর কি হতে পারে, নিউমোথোরাক্স হতে পারে, হিমোথোরাক্স হতে পারে। নিউমোথোরাক্স ইন্টারস্কেলিনিতে এত কমন না যতটা কমন হচ্ছে সুপ্রাক্লাভিকুলার, বিকজ এপেক্স অফ দ্য লাং ইজ হিয়ার। তো এখান থেকে যখন ইনজেকশন দিচ্ছি ওখানে আমার নিউমোথোরাক্স বা হিমোথোরাক্স হওয়ার চান্স বেশি। ওকে, আর একটা যেটা হয়, ড্রাগ এখানে বেশি দিলে হর্নার সিনড্রোম হতে পারে। আচ্ছা, সুপ্রাক্লাভিকুলার আর ইনফ্রাক্লাভিকুলারে ওগুলো বললাম, নিউমোথোরাক্স, দেন হিমোথোরাক্স, দেন there is chance of nerve injury as well, that নিউরোপ্র্যাক্সিয়া হ্যান ত্যান এসব হতে পারে। আর অ্যাক্সিলারি অ্যাপ্রোচে যেটা হয়, নার্ভ ইনজুরি হতে পারে, অ্যাক্সিলারি আর্টারিতে ইনজেকশন হয়ে যেতে পারে, বা লোকাল এরিয়া হেমাটোমা হতে পারে। তো those are the complications. তো এবার we'll be talking about the technique. We don't have much time over here. For technique আমি মুখে বলে দিচ্ছি, যেটা হচ্ছে first we'll make the patient supine. Okay, হয়তো right handed OT হচ্ছে, we need to make the patient supine. We'll turn the face to the opposite side and we'll go inside. We need to find out the lateral border of the sternocleidomastoid. Okay, এরপর ওখান থেকে you need to find out the anterior scalene muscle and middle scalene muscle. So there is a groove between the anterior scalene and the middle scalene muscle, that is the interscalene groove. You need to find out that space, and your point of insertion of the needle will be from that area and above the clavicle. Okay, one thing you need to mention to the patient, that when you will be going inside the going near the brachial plexus, patient might feel some electrical impulse on his or her hand, that is called paresthesia. Okay, so you need to explain that to the patient first. After getting the paresthesia, you will be confirmed that you are nearby the plexus. তারপরে you will be giving the local anesthetics over there. এটা হচ্ছে landmark technique. Otherwise we have PNS guided technique, that is peripheral nerve stimulator guided technique. In here we have a big needle, and along with the needle it is connected to a machine that is called nerve stimulator. Okay, so আমার নিডলটা ভেতরে গেল নার্ভের কাছে, আমি নার্ভ স্টিমুলেশন দিয়ে স্টার্ট করব। যদি ও প্লেক্সাসের কাছে থাকে, নার্ভ স্টিমুলেশনের জন্য হাতে মাসেলসে জার্ক হবে, ফিঙ্গার মুভমেন্ট হবে, আর মাসেলসে টুইচ হবে, সেটা দেখে উইল গেট টু আন্ডারস্ট্যান্ড উই আর নিয়ার বাই দ্য প্লেক্সাস, আর উইল ইনজেক্ট দ্য ড্রাগ ওখানে। আর একটা হয় ইউএসজি গাইডেড। ইউএসজি গাইডেডে ইউ উইল গেট টু সি দ্য হোল থিং আন্ডার দ্য ইউএসজি। তো যেটা বললাম সেটাই এখানে লেখা রয়েছে। ওকে, ইউএসজি গাইডেড। হ্যাঁ, এবার ইউএসজি গাইডেড টেকনিকে যেটা আমাদের একটা করতে হবে, মানে there is a punch line in USG guided technique, that is a bunch of grapes. USG তে all black and white. How will you understand that? Brachial plexus will look like a cluster of grapes or bunch of grapes. That is the punchline about the supraclavicular approach. You need to look for the bunch of grapes. When you see that, you put your needle over there and you give drugs. Okay, then comes the interscalene approach. Interscalene approach, again you need to make the patient supine, put the face to the opposite side. Now you find out two things: lateral border of the sternocleidomastoid and the cricoid. So these things will intersect. Okay, যেখানে intersect করছে সেইটা হচ্ছে point of entry of the needle. Okay, from there you need to put a needle, you need to go inside, গিয়ে you will be hitting a tubercle, that is called Shashnak tubercle. What is that? Spinous process of the C6 vertebra. Okay, ওখানে tubercle যেটা থাকে সেটা হচ্ছে Shashnak tubercle. So you will be hitting the Shashnak tubercle, একটু withdraw করে নিয়ে ওখানে ড্রাগ দিয়ে দিতে হয়। এটা হচ্ছে ল্যান্ডমার্ক টেকনিক। যদি পিএনএস গাইডের হচ্ছে, ওই একই ভাবে আমরা পৌঁছাবো, নার্ভ স্টিমুলেশন দেব, দ্যাট উইল কজেস দ্য মাসল টুইচ। ইউ উইল গেট টু আন্ডারস্ট্যান্ড কি তুমি মাসলের প্লেক্সাসের কাছে রয়েছো, ইউ গিভ দ্য ড্রাগ। আর ইউএসজি গাইডেড হলে ইউ ক্যান সি এভরিথিং। এখানে একটা যেটা আছে সেটা হচ্ছে ট্রাফিক সিগন্যাল সাইন, দিস থিং। তিনটে এই C5 C6 C7 এর যে নার্ভ রুট গুলো এখান থেকে দেখা যায়, লাইক যেমন ট্রাফিক সিগন্যাল থাকে তিনটে ওরকম। তো ইউ নিড টু সার্চ ফর দ্য ট্রাফিক সিগন্যাল সাইন ইন দ্য ইউএসজি when you are doing the interscalene approach. বাকি there is axillary approach. Axillary approach কিছু না, পেশেন্টের হাতটাকে সুপাইনেট করতে হবে আর অ্যাবডাক্ট করতে হবে। ওকে, করার পর you need to feel the axillary artery pulsation. Axillary artery pulsation এ you need to put your thumb. এবার এর ওপরে you have to prick the area and go inside. এর ওপরে ওখানে যদি তুমি ড্রাগ দিয়ে দাও that will block the median nerve. নিচে যদি ড্রাগ দিয়ে দাও that will block the ulnar nerve. And the radial nerve that lies behind or posterior to the artery. Okay, তাহলে যেটা একটা টেকনিক আছে যে through and through technique, you need to go through the axillary artery and you need to reach to the radial nerve. But সেটা একটু risky technique because there is chance of ওই আর্টারিতে ইনজেকশন হয়ে যাওয়ার চান্স থাকে, তো we don't prefer to do that. What we do, আমরা নিচ থেকে যাই, গিয়ে ঠেলে উপরের দিকে উঠে রেডিয়াল নার্ভটাকে ব্লক করি, that's it. Or you can do it by USG guidance. সব ব্লকেরই আলটিমেট ইয়ে হচ্ছে USG গাইডেন্স। সব অ্যাডভান্সড হসপিটালে, সব অ্যাডভান্সড ইনস্টিটিউশনে we use USG. Okay, so that is for upper arm surgery, we give brachial plexus block. সেরকম একইভাবে for lower limbs or leg surgery, for that we use spinal anesthesia. Other than that, মানে স্পাইনাল কিছু কিছু ক্ষেত্রে দেখা যায় পেশেন্টের প্রচন্ড, মানে কোনো পেশেন্ট খুব খারাপ বা আরটিএ পেশেন্ট, হ্যাঁ, তার সিভিয়ার হাইপোটেনশন অলরেডি হয়ে রয়েছে, তাকে আমি আবার যদি স্পাইনাল দিই আরো হাইপোটেনশন করবে and patient may succumb to death. So we don't do that. আমরা তখন কি করব, femoral sciatic nerve block করব। ওকে, তো ইন্ডিকেশন কি কি আছে, acetabulum fracture, femur fracture, above knee amputation, patellar fracture, tibia and metatarsal fracture। পায়ের সব ফ্র্যাকচার গুলো এই femoral and sciatic nerve block দিয়ে করা যায়। আচ্ছা, femoral ব্লকের জন্য আমি কি করব, ইঙ্গুইনাল লিগামেন্ট আছে, ঠিক আছে, তার থেকে 1 to 1.5 সেন্টিমিটার নিচে femoral artery pulsation পেলাম, তার ল্যাটারালি যাব আমরা, we need to give the injection, PNS guided করব, ওখানে গিয়ে আমরা নার্ভ স্টিমুলেশন দিলাম বাইরে থেকে। তো দেয়ার উইল বি টুইচেস অফ দ্য কোয়াড্রিসেপস মাসল, তাহলে কি হবে, প্যাটেলাটা এরকম ভাবে ফ্লিকার করবে, দ্যাট ইজ কল্ড প্যাটেলার ডান্স। ওকে, দ্যাট ইজ আ সাইন, if your patella is dancing means you have hit the femoral nerve and then you give the drugs over there, or else we can use USG technique. Acha, there is sciatic nerve block, there is a approach called approach of Labet or Labet approach, that is the mostly used technique, that is a posterior approach, otherwise lateral approach করা যায়, anterior approach করা যায়। ওকে, তো posterior approach এ পেশেন্টকে lateral decubitus posture নিয়ে যেতে হবে with the non-diseased leg or the non-fractured leg extended and the fractured leg slightly flexed over it. এই position মানে you can appreciate that এটা হচ্ছে non-fractured leg extended রয়েছে, তার উপরে fractured legটা flexed, ঠিক আছে। এবার posterior superior iliac spine, ঠিক আছে, আর এদিকে রয়েছে greater trochanter, এইগুলোকে মার্ক করতে হবে। You need to put a line from greater trochanter to posterior superior iliac spine, another line from the greater trochanter to the coccyx, tip of the coccyx। এবার ফার্স্ট যে লাইনটা আমি টানলাম from the greater trochanter to the posterior superior iliac spine, you intersect the line, okay, from there you draw a perpendicular line, ওই লাইনটা সেকেন্ড লাইনটাকে, এই যে এইটা হচ্ছে posterior superior iliac spine, এটা greater trochanter, এই লাইনটাকে ইন্টারসেক্ট করলে ওখান থেকে একটা পারপেন্ডিকুলার লাইন ড্র করলে, এবার গ্রেটার ট্রকেন্টার থেকে কক্সিস অবধি যে লাইনটা ড্র করা হয়েছিল এটাকে তো একটা জায়গাতে ইন্টারসেক্ট করবে, ওই ইন্টারসেক্ট পয়েন্টটা হচ্ছে পয়েন্ট অফ এন্ট্রি অফ নিডল। ওখান থেকে আমাদের নিডল ইনসার্ট করতে হবে। এবার পিএনএস গাইডেড হলে আমরা পিএনএস নিডল দেবো, নার্ভ স্টিমুলেশন দেবো, and we'll see there will be plantar flexion over there in the foot. Plantar flexion হলো মানে আমি নার্ভের sciatic নার্ভের কাছে আছি, and we'll give drugs over there, or USG গাইডেড আমরা করতে পারি। এবার একটা জিনিস সেটা হচ্ছে আপার লিম্বের বা ফোর আর্মের যা যা ব্লকস রয়েছে এগুলো সবই এই নার্ভ গুলো খুব সুপারফিশিয়াল, তো এগুলো ল্যান্ডমার্ক টেকনিকে করা যায়। লোয়ার লিম্বের যে ব্লকস গুলো আছে এগুলো ল্যান্ডমার্ক টেকনিকে না করাই প্রেফারেবল, তা ওগুলোতে ইউএসজি গাইডেড বা পিএনএস গাইডেড টেকনিকে করতে হবে। ল্যান্ডমার্ক টেকনিকে ইউ ওন্ট বি রিচিং ওভার দেয়ার, ইউ নিড বিগার সাইজ নিডল, যেটা ওই পিএনএস গাইডেড নিডল দিয়ে করা যায়। আচ্ছা, femoral and sciatic block done. আচ্ছা, one block is there, that is ilioinguinal iliohypogastric nerve block. আচ্ছা, ilioinguinal iliohypogastric nerve block হচ্ছে done in pediatric patients, okay, for like lower abdomen surgeries, like hernia surgeries, scrotal surgery, labial surgery, এগুলোর জন্য ilioinguinal iliohypogastric nerve block করা হয়। I'm not going into detail. Whatever you'll be doing, you'll be doing by USG guided technique, okay. And there is one transverse abdominis plane block, that is TAB block, that is important. আমরা যে রেগুলার সার্জারিজ করি তো তাতে আমার তো অ্যানালজেসিয়া দরকার, তো তার জন্য we do that transverse abdominis plane block. অ্যান্টেরিয়র অ্যাবডোমিনালের মাসেল লেয়ার কি কি আছে বলো, তিনটে মাসেল and transverse abdominis, তাহলে এটা হচ্ছে ইন্টারনাল ওবলিক and transverse abdominis এর মাঝের লেয়ার, ওকে। that is a fascial plane and the nerve lies deep to the fascia. We go inside inside that fascial plane. We do it according like USG guided or PNS guided. ওই প্লেনে পৌঁছালাম, we give drugs over there, and that's it. So that will give anesthesia mostly to the lower abdomen surgeries or obstetric surgeries, like that. So that's আচ্ছা, যেটা হচ্ছে এটার একটা জাস্ট ইউএসজিটা আমি দেখিয়ে দিচ্ছি। You can see the all three layers, external oblique, internal oblique, and transverse abdominis. This is the transverse abdominis plane, okay. You need to go over there. You'll putting a needle over there and you'll inject the drug. When you'll be injecting the drug, you can see a hollow space over here, that is the internal oblique and the transverse abdominis, and inside here there will be the local anesthetic. Those layer will be separated by the drugs.